a nurse that also happens to deal with trauma patients in a helicopter. Hello, podcasting world, and welcome back to the Core Console RX podcast. My name's Mike Corvino. With me, as always, Cole Swanson. And today we are joined by my new buddy, Alfredo, coming from all the way from out in California. Alfredo, what's up, man?
Hey, man. How's it going? Glad to be here.
Good, good. Glad to have you here. Thanks for doing this. So I saw
Appreciate it.
Alfredo on Instagram, actually, and I was looking through his profile. And he followed, one of us followed the other one, and vice versa. And I was looking at his profile, saw that he was a RN, but also saw that he was in the military, and saw him in a flight suit and an awesome-looking helmet. And I quickly realized his job is much, much cooler than mine. And so I wanted to have him on the show to kind of discuss what he does and get some insight into that. The life of a what's the correct term of it? Is it it's not a flight nurse? Is it like
it's basically it's flight nurse. Yeah,
flight nurse. Okay.
Flight nurse.
Cool. So how did you get started in that?
So my career as a flight nurse was basically like cumulative of a few years of experience. So even before I was able to apply, I had to get 3 years of ICU and ER experience to be considered. On top of that, I had to get like a national certification, either like a CCRN or a CEN, any kind of specialty certification. And once you get that, then they'll consider you for flight. So I had a colleague of mine that went from ICU to Skylife here in Fresno facility. I went ahead and, contacted the manager, and he went ahead and gave me a shot, so it was great. But even prior to that, I had a friend of mine in the ER mention it to me when I was a brand new nurse, but at that time I wasn't qualified with my training and with my certifications. So I had to wait until I got all those things under my belt, and then I was able to apply.
Awesome. That's cool, man. So what's your path now? Are you still doing the nursing thing? Where do you go from here?
So right now I'm currently in National University's anesthesia program. It's a master's program, and once I complete it, I'll have a master's degree in anesthesia, nursing anesthesia. So that'll be 2 years. Unfortunately, I can't work during that program because it's so demanding.
Right.
As much as I'd love to. I can't do it. So right now I'm currently just in a per diem position at Skylife. So if I decide once I'm done with anesthesia, if I want to pick up a little there or pick up as many hours as I want, I can do that, and also do anesthesia. So it's really flexible as far as what I can do there.
Right. So how long did you actually do the flight nursing?
I did it for about a year.
Okay.
For about a year.
Awesome. Yeah. Was it pretty intense?
Yeah. My very first scene call was crazy, man. So it's like about 8 o'clock in the evening, and we get toned out for a traffic accident at 5 Points, and we're told that it's a newborn trauma. So we stood up, and pediatrics and things are not something I'm super comfortable with, but I said, well, we gotta go, and we load up and we get to the scene, man, and it's just a pretty graphic scene. You have a patient who traumatically delivered through the abdomen. We have the baby at the floorboard of the car, and
oh my gosh,
both patient. There was a couple 1144s in the whole scene, and what made it a little more complicated was that we had to pick up another patient and take them both in the small helicopter to RMC. So it was pretty intense, lots of adrenaline, and
yeah.
But we did what we could for them, and we looked back at the call, and we did what we had to do.
That was your first one?
That was my first one. I was
Jeez.
Orienting, and that was my very first scene call, and it was pretty traumatic.
That's crazy. So it's
Yeah.
you, a nurse. Who else is kind of on the team with you in that situation?
So in that situation, so the usual care team involved, like in in a team is you have the flight nurse, you have the flight paramedic, and then you have the pilot. So it's just you three coordinating the whole show, and
Right.
usually the flight nurse is the primary, caregiver, and then the
Right.
paramedic is secondary. But I'll tell you, some of these paramedics that I work with, they're sharp, man.
Yeah.
They know a lot, and it's a great resource for new younger nurses coming in that still need a lot of growth, to go. So
Yeah. Is the pilot trained medically in any way, or is that just flying the copter?
absolutely not. They're just completely, you know, uh, focused on flying the helicopter, and that's it.
Right. Right. So can any paramedic get certified and do that, or kind of how does that work as far as they go?
So the paramedics usually, every program is a little different to some degree, but the paramedics here, they have to have been a paramedic for about 3 years,
Okay.
and then they have to go and take their flight paramedic test and pass that to be considered for a position.
Right. Man, that is pretty fascinating. Um,
Yeah.
would you go back and do it again if you could, or would you have gone a different route?
Oh,
Yeah.
no, I loved it. I loved it. It was, because you don't know what you're gonna see on any given shift. Every shift is completely different. You'll get, one shift you can get a bunch of pediatric calls. One shift you'll get a bunch of OB calls, and then everything in between. So it's just the variability is amazing, and we get to go all different places.
Yeah.
On a given shift, you can go up to the Bay, drop off a patient, go to LA. We go up to the mountains up in Yosemite, respond to scene calls up there.
Wow.
We go pretty much anywhere. I've done a scene call out in Tonopah, Nevada, for an amputation. So I mean, it's cool. All the different things we can do.
Yeah. And do you take them to whatever the closest hospital is, or are you always going back to your home base and bringing them there?
Yeah, yeah. Our main focus is always getting the patient to the closest appropriate facility.
Right.
So that, if we're out in Nevada, in that situation, we took that patient to UMC in Las Vegas.
Gotcha.
Yeah.
Awesome. So backing up a little bit to nursing school, did you always know that you wanted to do something post RN, or were you just focusing on the RN at that point, and then throughout the few years getting certified in other things, working in various areas, did you say, okay, I want to consider something else?
Well, originally I worked at a little hospital, and one of my close friends now at that time had just been accepted to an anesthesia program out in Buffalo, New
Okay.
York. And, or I'm sorry, excuse me, in Brooklyn, New York. My other friend got into Buffalo, but, I told him, I was like, hey, I want to do anesthesia. And he showed me the email, and he kind of helped me set up a plan and kind of, put in place a path to where getting closer and getting to anesthesia as fast as possible. So we talked, and then we've been talking in the whole process. And I made it a pretty important deal to get into ICU right out of, nursing school. I got
Right.
into ER. So my first 2 years were kind of rough. The learning curve was rough.
Right.
But I did 2 years full time of both. So I was working 12-hour shifts a week
Jeez.
for 2 years. And then the good thing about that, though, is it opened up a lot of other opportunities. Like, for example, from there, I was able to go to the level 1 trauma facility here in Fresno. And then shortly after that, I was able to do flights. So I've only been a nurse for about 3.5 years. But being able to work with some of these really seasoned nurses has really helped me out, because, I like to learn, and I think it's a never ending journey to learn in this field, so
Yeah.
I'm very happy to be here.
For sure.
Yeah.
And does CRNA, do they have a certain amount of experience that you have to get before applying? Because people don't generally apply right out of school for that, right?
Correct. Yeah, that is correct. Usually, from what I've seen in researching all the programs, most of them, the bare minimum they would like to see their applicants have is 1 year of critical care experience. But usually the
Gotcha.
recommended is 3 to 5.
Wow. And that's critical care specifically, not just 3 to 5 years of, whatever floor,
Yeah,
whatever general nursing.
exactly,
Huh.
exactly. Yeah, usually they like, CVICU. They like these big facility ICUs, just
Right.
more sick patients.
Right. Awesome. That's cool, man.
That's cool, man. And I like what you said about, you were working 12 6-hour shifts. Like, that's brutal. But you knew what you wanted and you went after it and freaking worked hard. Like, I'm a huge fan of that because I hear so many people talk about wanting to do this, wanting to do that, but they're not willing to put in that extra work, that hard work to get through that crappy time to get to where they want to be.
Yeah, man.
And that's huge, man. I think
Yeah,
so many students need to hear that and see, because I mean, you're a young dude, and to be able to have your head on straight and think like, okay, well, it sucks now, but later it won't. I think is a
exactly.
quality that most people do not possess, and it's super super important. So that's cool to hear. I'm glad you brought that up.
Yeah, man. I mean, it's just if you want something, you got to go for it and give it everything. The faster and the harder you work for it, the faster it'll come to you. Like, I could have taken an extra year off or just, taken a little bit slower, but I was on a mission, man. I'm like, I want to get into anesthesia school as fast as possible. And, like I said, man, it wasn't easy at all. Like having just one day off a week for 2 years, and I was beat, man. I was tired, but, when you're ambitious and you want to learn and you want to go someplace, just suck it up, man. You got to suck it up and do what
Heck,
you got to do.
For
heck
sure.
yeah.
Yeah.
Well, so I mean, this is super off topic from anything medical, but I'm fascinated by this. So, what do you think? Because I feel like I'm the same way. I'm driven. I think Cole's the same way.
Yeah,
I know what I want, and I'll work as hard as I can to get it. So, for you personally, like, what do you think? Like, what was that? In, as bringing up as a child. I mean, were your parents just like spot on with how they raised you? I mean, were you just around people that were really motivational for you? Like, what was your thing to instill that in you, since it's such a rare trait? How do you think
yeah.
you was born that way, or what's your thoughts?
I honestly, well, I come from a migrant family. Both my parents came out here, with nothing, and they made something of themselves. They were able. We were never rich. We were never, flashy, nothing like that. We always had enough to be happy. And my parents always did their best. They always worked very hard. But then, my dad passed away a few years, like right before I started nursing school, and I told myself that I was going to be everything that I could be, and I wasn't going to waste any time just kind of drifting in life. I wanted to set up a plan, a very specific focused plan to get where I needed to get. And, and even when I become a CRNA, that's not the end of the journey. There's still a lot of other things I want to do. I want to give back to people, donate and just help other people come up. I think that nowadays, man, a lot of people are just very hateful towards each other, and we don't come together to help each other out. I think we need to pull each other together. That's why I like social media, because I feel like sometimes I'll post something and then, a nurse from like the other side of the country will message me like, hey man, how did you do this? Or how did you do that? What do you think? Am I doing this? And, we get to network, and it's amazing, man. It's amazing because we're all in the same, fight for what we want to do, so it's cool doing that. But I just think, man, if you are willing to be disciplined and consistent, failure always happens. That's part of life, but if you can say like, all right, well, I failed at this, but I'm going to, continue my journey towards my goal, then anything's possible, man. But I think my biggest thing too in having this attitude is I study best practices. Like, if I want to be a rich person, I study rich people. If I want to be a bodybuilder, I study bodybuilders. What do they do, that I could learn from to become someone like them? And so I read a lot. I listen to motivational speakers. Anything I can learn to help my life out from any perspective. That's what I do. I just learn from other people.
Heck yeah, that's
Cool, man.
awesome.
Yeah, and I like what you said about social media because it really does a great job of connecting people, and we're trying to use it to connect a lot of different types of healthcare professionals. And we love having nurses follow us because I feel like they interact a little bit more than maybe some others, which is really good, commenting and giving good recommendations on things. Nurses and nursing students, and we actually have a lot that follow. My sister is one, and she's actually graduating from nursing school in about a month.
That's
So
awesome.
Going back to you in nursing school, there's a lot of options for nurses, postgraduate, post RN. So what steered you towards CRNA? And I'm aware of nurse practitioner, and but what other options are there, and why would you choose one or the other if you're talking to a nursing student?
So if I'm talking to a nursing student, first and foremost, there's a lot of avenues you can take towards different paths. Like you can do FNP, you can do midwife, you can do anesthesia. Anesthesia for me, I just like how competitive it is, how demanding the program itself is, and how in depth they get. Like one of my instructors was telling us is, you're going to be a specialist in anesthesia. That's going to be like your thing, and I want to be able to say, okay, I'm excellent in anesthesia. I'm a good provider, but it really comes down to what interests you most. I like, anesthetics. I like how they work. I like trying to understand how they affect the physiology in the body and things like that. And, we get to do a lot of cool things with the airways. We get to intubate, central lines, A lines. There's a lot of hands-on with it too, but not FMP. Nurse practitioners can't do that. They can do it as well, but that's just the route I took. But it's just what you're passionate about. If you want to be a emergency nurse practitioner, if you want to be a geriatric, pediatric, it's just what motivates you, what interests you most. I think is the route you should take.
Yeah, for sure.
So what are your thoughts? You were talking about like wanting to help and people getting along and all that, and which is awesome. What do you think about it in the medical field? So one of the things I've noticed, when I was in school is, I went to a school that was very pro interprofessionalism. So like they made us do projects with the nursing students, even though we were in the PharmD program. They made us work with some of the medical students to get us used to working with people in different specialties. And, versus some places I see it's very cliquey, pharmacists hang out with pharmacists, nurses hang out with nurses. I think that, me personally, I'm a huge fan of interprofessionalism and promoting that. What's your thoughts, and like, what's been your experiences working with other healthcare professionals?
I think it's always a collaborative effort, man. You're always not going to have the same ideas or you're not going to agree on the same things as other people. That's just natural in our workplace. But I think, communication is very important. If there's something that, the patient needs and you are concerned about it, bring it up to the doctor, and maybe they don't want to do anything. It's about communication, talking to other people. Hey, what do you think about this? But I think that when you get to your workplace, you got to leave all the stuff out the door, man. And you're there to be there for the patient, and you're working as a team. It's not a solo effort. You got to remember that you're not the only one there, and there's resources. If I need help with my ventilator, okay, I'm going to call the respiratory therapist. Hey man, this is what I think. What do you think? Or hey, I need to start feeding my patient. They haven't been fed for X amount of days. All right, I'm going to contact the dietitian. Hey, can you help me get my patient on the regimen and anything and everything in between. It's just about coming together as a team, man, and professionalism. That's absolutely true, man. Like you were talking about, not gossiping on the floor. It happens. It's part of our workplace. People tend to talk about other people, talk about things that are not pertinent to what we're, handling at work. And professionalism is absolutely crucial, man, because you don't know, like, when someone's going to overhear you say something, or you make a joke and it's offensive, whatever. It's just being a professional. We are professionals. From any perspective, we have to remember to be professionals.
Definitely, yeah.
And I like what you said too about if you needed help with with one of the vents or something, you go and talk to the respiratory therapist. I feel like there's this not stigma, but there's this thought of like, oh, well, this person didn't go to school as long as me, or I'm more specialized in this. And like every one of us has our specialties. And I see PharmD students doing it too. It's like, you'll hear them saying, oh, that guy, that's the med that they're going to use. That guy must be stupid. I'm like, really? They're, stupid? Or is it just maybe that, they just weren't familiar with that particular part of pharmacotherapy? And, that's one of the things I always encourage, like students that I work with, is it's like, everyone has their specialty, everyone has their role, and you need to respect the other roles, because nobody wants me putting them on a vent. I'm the last person on earth. They'd be better off getting the janitor.
Yeah.
but it's like everyone has their position, everyone has their specialty and their skill set, and like respecting the other skill sets for what that is, and like taking the ego out of it. There's so much ego in freaking healthcare. It's unbelievable.
Yeah,
but
it's true, man. It's and it's not about that. Like I said, when I come to work, I just check myself. Like, look, man, you're here to, be a resource to your patient, and it's a collaborative effort, man. I don't think I'm better than any other nurse. I feel like I'm there to learn too, man. If someone teaches me something or I'm wrong, cool, man. I learn the right way, and then I bring it to the table the next time. You just got to be humble about it. You're there to learn, and it's a lifelong learning process, man. So we're never going to be completely masters at everything. We're just, trying to get better every day. At least that's my motto. I try to get better every day, learn something new every day, and
that's awesome.
Just be more of a resource to my patient, man.
Heck yeah. Every single post that I put on Instagram always has #LearnEveryDay, because I feel like if you didn't learn something new that day, then as a healthcare professional, then you didn't do something right. I think every single day you can spend 5 minutes learning something you weren't familiar with. I think that's huge. Man. When you're a healthcare professional, I think you sign up ahead of time. You're going to make good money. You're going to have, this, that, and the other, but you also signed up to be a student the rest of your life too. So.
Yeah, man. And I think another thing that's pretty important, when we're talking about this, is just going out and learning on your own,
Heck yeah.
That's another thing that's just so important for me. Like, I like to read like nursing books or pathophys books, anything that'll help me become a better provider, because I'm not the smartest, cat, compared to other people. So I just have to constantly, renew my knowledge to reinforce what I already know, and then just to learn what new things are coming out. Because I feel like, healthcare and medicine is just constantly evolving, man, at such a rapid rate that I feel like I can't even catch up. So I think just taking the time to read, in my specialty, and learn more is only going to be a better asset. So I just think, if I'm talking to new students, I'm like, just always take it upon yourself to read a little bit every day, learn something new. And before you know it, you'll know a little bit about a lot, a little bit of different things. And it just makes me more resourceful,
Heck yeah.
For sure. Yeah. And I think everybody feels that way sometimes, that they're not the sharpest knife in the drawer. I mean, you're definitely not looking at the two smartest pharmacists in the world, but
nope.
We've got a podcast. So.
Yeah, no, it's because people ask me like why I read every day, and like this thing, because I'm not the sharpest tool in the shed, so I have to, I have to work a lot harder than some of the other people out there. But no, I mean, I think too, like, what I like is, you're such a normal dude, and like seem like a cool guy, and like you don't have that, you see some people that are like, oh, I don't want to be reading every single day, because then like they have like this picture in their mind of like a bookworm or like some big nerd, and I'm like, you can be a normal person, be a cool person, and like still enjoy learning, and that's the huge. I mean, that's why I don't try to change the way that I talk. You'll hear me say dude and things like that in the podcast, and I probably shouldn't for professional reasons. Some people may turn it off, but I mean, that's just how I talk. That's how I am. So, I just am a combination of, I grew up being a surfer, and, I was a professional MMA fighter for a little bit, and then I also happen to love pharmacotherapy. So it is what it is.
Just drop that in there real smooth, nonchalant.
No, I've said it before, I think. So. Awesome. So, it's just, I like the different side of things. So it's good. I try to push that on students. I'm like, there's nothing wrong with, reading every day, or, being a little bit of a nerd. You don't have to look like one to be a nerd.
Yeah, man. I mean, like Stephen Covey says, man, he's like, the half-life for what you currently know is about 2 years. So in 2 years, if you don't just take it upon yourself to learn something new, you're just going to lose half of what you already know. And it's like, I think it's just so important, man, to continue to just learn, man, and, in another book I read by Wallace Wattles, he says, the moment you stop learning and start advancing is when you start dying, technically, And I was like, it makes sense to me, because it's like, I could be a better person in this, or I can be a better person in that. Even non-medical, man. I'm talking like motivational, better relationships with other people, better communication. It's just, if there's something that I'm weak on or I can get stronger in, I just take it upon myself to read a little bit about it, to see how I can make my life and my whole being better, to other people,
Absolutely.
That's huge, man. That's awesome. That's really cool and encouraging to hear. So good stuff, man. So what would you tell somebody coming up, and Cole kind of, started on this path. Someone's coming up as a nursing student, and you kind of establish where they want to go with their career and stuff. What is some advice you would give them? Someone who's starting nursing school, what's some advice you would give them, like on a day-to-day basis, or like if they're going into their rotations or clinicals or whatever. What's some advice you would give them as far as starting out and like things to look for or keep an eye out for?
Yeah, I would say, just embrace the suck, man. There's gonna be times where you're gonna hate it, waking up at like 4 a.m. to be a clinical by 6 or whatever. But you just gotta embrace it, man. It's part of the process. It's the journey, that I look back and I'm like, man, I made it through some of those things, and I'm like, it's amazing, So I think just being disciplined and consistent, not taking no for an answer, and fighting for what you want. If you want to be an ICU nurse, don't settle with being a med-surg nurse. If you want to be an ER nurse, don't settle for anything. What I'm saying is just, if you want something, go grab it, and fight for it with your life, because it's for you. It's no one else is going to come and say, hey man, here, you want this position in ICU, or you want this scholarship, or you want this or that. There's a lot of things out there that you can get, like for example, with me, when I first started school, like I said, my dad had passed away. So we were kind of in bad shape financially, and I didn't know how I was going to do it, but, I fought for some scholarships, and I said, all right, man, the likelihood of getting most of these is not good, but I got a couple and it helped me get through. So it's just being persistent and just being hungry, man. Just going out there and grabbing it, killing something and bringing it back to the cave, That's just how it is.
I love it, man. I love the analogies too. I feel like you're the West Coast version of the stuff that I say. That's awesome, man. I love it. No, that's good stuff. So, what are some of your go-tos as far as staying relevant in the medical field, in your field? What are some of your resources that you use to stay up to date on things?
I like to use mostly a lot of books, a lot of newer published books, new information, because sometimes some of the older stuff has a little bit different, techniques and a little bit different information as far as some of the newer things. Like I said, things are changing at such a rapid pace. Like, nowadays, like for example, with trauma, we were told in the past to, give them LR, give a lot of fluid, but now we're like, okay, it's looking like we should transition to colloids versus crystalloids.
Right.
That's what they do a lot in the military too. That's, they start off with colloid versus crystalloid, and they've seen that promotes better patient outcomes. So just things like that, staying relevant, trying to keep up with the evolution of medicine, and things like that.
Cool.
So you have a pretty big following on Instagram. You got like 13,000 people following you, which is awesome. What do you think social media, or do you think social media has a place in continuing education, especially going forward in the future?
I think it does. I think it really does. There's a lot of individuals that like to post relevant information as far as practice and things like that, evidence-based practice. So I think social media, sometimes I'll learn a lot from just looking at people's profiles. They'll like, post something about like open heart surgery, medications and things like that. And, I think social media has a huge influence on, staying relevant in practice and in medicine and things like that.
Yeah, I do. Cole, what do you think?
Sure. We're doing what we're doing, aren't we?
Yeah, it's true. Yeah, I'm a huge advocate for social media, and I think Cole's starting to go down that route as well. But yeah, I think that it's just one of those things that you have, if you use it the right way, and you have these people on there that are people you would never meet in another setting because they're across the country, like in this particular case. And I watched an ophthalmologist do some kind of an eye surgery the other day on his Instagram story. Like, I was like, this is crazy. Like, this would never happen. Like, that's nuts. And there's just so much out there now, and people using it the right way. And not that there's anything wrong with taking pictures of your food, but it's just there's one of those things that you can learn a ton. And I think that people who kind of shun social media as if don't be on that because it's not professional, it's not this, that, and the other. Like, it's a mistake, especially going forward. Like, it's not going anywhere. It's going to get more involved in our lives.
Oh yeah.
I think it's definitely going to be the platform to learn on here in the next 5 years or so. I
agree with you 100% on that. It's just such a big part of our lives, like you said, man, that, most of what we're going to be using is social media for future reference, and it's just amazing how you can, like I said, you can use social media to teach someone, who's all the way across the country or talk to them. And it's just amazing.
Yeah. It's awesome. So what about Alexa, Amazon's Alexa? Have you messed with that at all?
I haven't, to be honest with you. I'm not very, I'm not very involved with the whole Alexa thing right now, but like I said, those are all things that are just getting so advanced, and I got to take the time to learn a little bit about it because I know a lot of people talk about it.
Yeah, it's pretty cool. I have a flash briefing on Alexa, so like it'll update you if you say what's in the news and you subscribe to it. It'll tell you it's my voice will come on and it'll talk about the new drug or a new study or something like that. But that's been pretty cool too, and I feel like it's something that nobody's really on right now, and so it's kind of like the land grab, and so. I think 5 years from now it's going to be pretty huge. Probably less. Probably won't take 5 years. Probably take 2 years. But where everybody's on it, and then everyone's going to be like, "Oh, we should start using this for education." So I'm trying to establish it now.
Yeah, that's so true, man. Because I think nowadays, man, it's just the essence of time. We're just living faster than we've ever lived before. Now time is just such a we just don't have enough of it. And it's like. Anything that'll help us do things faster, like you said, that whole Alexa thing will talk to you and like you just ask it for whatever you're looking for, and it just helps you, have to waste less time. It's amazing.
Yep.
I had like kind of like an epiphany the other day too, because I was trying to think of like time in the sense of like I get it, like it's faster to use your voice to like call your Uber or something like that, but I was thinking about it, and I was like playing through some this trivia game on my phone to get ready for the certified diabetes educator exam. Just practicing questions on there. I was like, man, this would be awesome if my Alexa would just like read off the questions to me, that I could answer with my voice, so I could multitask while I'm doing this. I was like, oh yeah, that's another just a perfect example of when I would use an Alexa for something. And voice.
Yeah, that's a very valid reason to use that, man. That'd be pretty cool.
Yeah.
I would like to use something like that just to, ask questions maybe right now for tests, that I'm having coming up. That'd be pretty cool, So it's amazing that those things are going to be probably happening soon, like you said.
Yeah, I bet.
Yeah, just people working on maybe me.
Don't steal that idea.
Yeah. No, that's why I like to put it out there, because I don't, it's one of those things. You're the kind of person that I think would jump on it and jump on Alexa and actually do the work, but 99% of people won't. So I just tell everybody what I'm doing and how I'm doing it, because I don't think that they're actually going to do it anyway. So, and if they are, that's awesome. That means they're a player, and I'm happy to help them. So.
Right.
Yeah, that's right, man. That's right.
Yeah.
All right. So what? Anything? We're gonna run over some new drugs, because we don't have a patient case today, but we are gonna go over some new kind of random drugs that were approved in the last 4 weeks?
Yeah, month-ish.
So some of these run into the end of February. Is there anything you want to add on before we jump into this kind of next section and start going over some drugs real quick?
No, let's do it, man.
All right, cool. And then, by all means, throw in your 2 cents about these two. So don't let us steal the show on this one.
Oh, no, man. You guys are the experts, I'm learning from you guys in this aspect today.
There you go.
In theory, I guess. Right. We're the experts. All right, let's see.
You want to talk about the big one first? Biktarvy?
Yeah, so we could, you want to start off with that one?
Okay, sure. So this was approved more like late February, and you can jump in on this one too, because I think you have a a buddy who is kind of involved in this, but Biktarvy is a new drug approved for the treatment of HIV. It's a combo, like most of the HIV drugs, with bictegravir, emtricitabine, and tenofovir alafenamide. It's essentially adding on the bictegravir component, which is an integrase inhibitor, onto Descovy, which was just the emtricitabine and tenofovir alafenamide. It's from Gilead. They've been kind of on the forefront of a couple new HIV drugs in the past. The FDA looked at 3 studies to get it approved, and they were all pretty promising. So this is one, because, HIV drugs, it's pretty important whether you take them with food or not. This is one where you can take with or without food, which is pretty cool, I think. So I think in the future, this will be part of regular HIV treatment for now. Is it expensive? Is it covered? Hard to say, but it's an interesting one.
So one of the reasons they were so excited about bictegravir was it's the first non-boosted integrase inhibitor that has been in corporation with the Descovy, the tenofovir alafenamide, emtricitabine. And so the other one, Genvoya, was elvitegravir, but it was given with cobicistat. So it was a boosted integrase strain inhibitor. And so there's more drug-drug interactions, things we had to worry about, whereas this one is non-boosted. It's just the integrase strain inhibitor by itself.
Yep.
The only other combination that had 2 nukes with a integrase strain inhibitor was the Triumec that had abacavir, and then dolutegravir was the integrase strain inhibitor. But then because it has abacavir in it, you have to worry about the hypersensitivity reaction possibility, so you have to do genetic testing and worry about that. So this is definitely something that people are very excited about, and the results look very, very good as far as suppressing viral load and raising CD4 counts.
Yeah, and it does have a black box warning for severe acute exacerbations of Hep B infection, so something to be aware of.
Have we talked about TAF versus
no,
old
I don't think so.
formulation?
You did a post on it, but not on the podcast, I don't think.
Okay, so just in case someone is hearing tenofovir alafenamide, not knowing what that is. So the tenofovir is the active drug that we're using. It's the active nuke. The old version of tenofovir, disoprosyl fumarate, was a drug that's been used for years now. It's very, very effective, but the problem is the longer you use it, you get more bone mineral density loss, you get more renal toxicity over time. And so it's now that these HIV patients are living basically full lives, we want to limit, obviously, what they're experiencing in regards to toxicities. And so the reason why it was getting this buildup in the kidneys and causing issues is because tenofovir was given as a prodrug, because it won't be absorbed as in its active state. And so the old formulation was very quickly metabolized, and most of it actually stayed in the plasma before it ever entered the target cell. And so it would be excreted in the kidneys, and it would cause damage and things like that. So this new version, tenofovir alafenamide, has a much slower metabolism, and so more of the active drug actually gets to the site of action, and so you have less free concentration of tenofovir in the plasma, and so it's able to do its thing in the target site where it's actually supposed to be. And so we see significantly less. Basically, right now we don't really have data that shows any kind of renal toxicity or bone mineral density loss, and I think we have the data up to 144 weeks now. So it's a big deal, and since about 2015, they've been actively switching the formulations over to TAF is the nickname for tenofovir alafenamide. They've been switching those over to from the old formulation of tenofovir to this one to protect those patients, especially the younger ones that are healthy. We want to limit how many problems they're coming into contact with as they get older.
Yeah.
Cool.
It's really amazing that like 20, 30 years ago, it was almost a death sentence. And now, I mean, with these new medications, it's pretty incredible.
That's amazing.
Yeah.
And there's also a monoclonal antibody that was approved this month for HIV as well. Mm-hmm. And that's the first of its kind, and it's definitely a very novel mechanism. And they've been talking about using monoclonal antibodies for a while. They finally got one approved, and it actually showed to be effective in multi-drug resistant virus strains. And so these patients who normally would have to switch out their oral meds because they're resistant to, tenofovir or whatever it ended up being, they can use this new monoclonal antibody and hopefully still get viral load suppression and increase their CD4 counts.
And that's Trogarzo, right?
Yes.
That's
a huge one.
Generic, we'll go with Ibalizumab.
Yes.
Is that the best we can do?
That's
-UIYK.
Yeah.
Best I can do.
Yeah, I think that's how you pronounce it. Somebody from, what is it, Talmed, whoever owns those can correct us. But, that's a new monoclonal antibody and definitely a very cool one. The other HIV med, because a lot of HIV stuff this month, Simduo was the lamivudine and then tenofovir disoproxil fumarate. So it's the old formulation of tenofovir, and it's supposed to be used in combination with another agent. So it's not approved to be used by itself, and I don't know if that's what they're going for with it, but I guess this is okay for a patient who doesn't have or can't take emtricitabine, but typically the tenofovir used with emtricitabine is the one that everyone uses. However, they had to use the old formulation of tenofovir because that's the one that went off patent. They can't use the new formulation. So I can't think of too many reasons why they would use this. Maybe they're going to start trying to use it in PrEP for pre-exposure prophylaxis. In high-risk patients, that might be the thought process. But I haven't seen too much data on it yet, but I wasn't as nearly as excited about this one.
Yeah, a lot of good HIV stuff. Another new one that came out in February was Erlita, maybe. Apalutamide. It's an androgen receptor inhibitor used for the treatment of prostate cancer. Definitely no expert in prostate cancer, so I'm not exactly sure where it would fit into therapy, but it binds directly to the ligand binding domain of the androgen receptor. It essentially messes up the DNA and kind of suppresses that and hopefully helps induce remission of prostate cancer. And the trial that got that approved was called the Spartan trial.
Nice. I like that.
Yeah.
It's the Spartan trial.
So
the other one that I thought was really cool, Ilimia, was Childre injection.
Nice.
And that was for plaque psoriasis. So this one was studied, and they actually compared it in the Resolve trial, compared it to Enbrel, and seemed to have superiority. I haven't gone through the study yet with a fine-tooth comb or anything like that. It was approved on March 20th, but this is definitely one that seems to be pretty cool, and the mechanism is a little bit different than some of our other ones. So this is actually targeting Th17, so T helper 17 cells, and that is a mediator, if you will, for activating eventually TNF alpha. So it's kind of moving up the chain of inflammation and a little bit farther versus our TNF alpha inhibitors. The one issue that even the authors recommended or discussed rather is that the Enbrel was one of the main medications that they were using at the time when they started the study. But now that we have a little bit better, TNF alpha inhibitors as well as the 17A interleukin inhibitors, so Cosentyx and Taltz. I probably just butchered the class, but they have maybe would have gotten better results if we had, or maybe not have gotten as good a results if we compared to one of those, as opposed to being superior to Enbrel. But definitely a novel agent, and there's another one that they're working on getting approved from a different company that works in the same pathway. So adding another weapon to combat plaque psoriasis.
Cool. And another new drug, novel medication that was approved for the treatment of another pretty bad disease, cystic fibrosis, was Symdeko. It's a combination of tizacaftor and ivacaftor. Basic mechanism is that they act on the CFTR, the cystic fibrosis transmembrane conductance regulator, which mutations in that gene are a big or take a big responsibility in causing cystic fibrosis. And in 3 trials, the endpoint was essentially improvement in lung function, so an improved FEV1, and it did show that in its phase 3 clinical trials. So seems promising for something where there's definitely limited treatment long term.
Yep. One other one that I saw that we can mention, or unless Cole, you feel free to keep going if you have more. Apidaz is acetaminophen and benzhydrocodone, which is a prodrug for hydrocodone, and so I don't think that they've actually been able to prove that it is a deterrent as far as abuse, but it is a prodrug, and so you can't inject it, I guess, is their thought process, because it has to go through hepatic metabolism in order to become activated, and so that was approved at the end of February. With that being probably very expensive, I haven't seen the price on it. I can't imagine it's going to be used too often, but it is on the market, so if you happen to see it, now you know what it is and why it's different.
But I suppose orally it could still be abused, right?
Yeah, that's kind of what I'm thinking. So I don't really know. I guess it goes cut back on IV use, but if you take a bunch of them, it's still going to be the same.
Yeah, I'd like to look a little further into that. Maybe there's like a decreased high. I don't know. Who knows?
I'm pretty sure they actually said something I read said that it's not a true abuse deterrent, or they can't prove that it actually cuts down on abuse. So
gotcha.
Unfortunately, I don't think that will. But yeah, it's a good thought.
Yeah, sure.
Cool. So, any other drugs you want to talk about?
No, that's all the big ones, I think.
So yeah, we should really rehearse this before too, so we can actually like pronounce the names and stuff too, instead of just ad-libbing.
It's It builds character.
Yeah. Cool. So there's gonna be somebody listening to these going, "That's not how you pronounce that, stupid."
Email us, tell us, we'll correct it. Right?
Yeah.
Or we'll just say, that's how we correct. Yeah, that's how we pronounce
it. We'll correct it next time.
Cool.
All right, man. Alfredo, anything else you want to go over, man, before we go? Anything you want to add? Any cool new stuff in the nursing world that we need to know about?
No, man. I think that's it. I think, man. I'm glad to be on this show with you guys, and if anyone has any questions or I can help in any way, feel free to contact me or whatever, man. I'm here to help.
Sounds good. So I'm gonna put your Instagram handle in the video, and then I'll put it in the comments for the other websites if that's cool with you, and then have people send you a direct message on there if they have any questions or anything. Anywhere else besides Instagram that people should look for you on? Or is Instagram your big one?
That's mostly, that's my big one there. That's where I'm 95% of the time. So I like to keep it to just one for now. With school going on and stuff, I'll focus on Instagram for now.
I hear you.
Sure.
Well, you're doing a heck of a job on there, man. Like I said, that's a lot of people following you and checking out what you're doing. So very cool.
Yeah, thanks, guys. I appreciate it.
Absolutely. So next time you get like a really cool patient case or something like that, let me know so we can have you on. We can do a critical care nursing case. That would be pretty awesome.
Yeah, that would be awesome, man. I'll keep an eye out for some of those, or if you guys have anything that I can help out with. Absolutely.
Awesome.
Sounds good, man. Well, I really appreciate you taking the time. I know you're a busy guy, and then we'll be in touch. Appreciate everything you're doing.
Yeah, man. Hey, likewise. Thanks for having me on here. I appreciate it, guys. You guys have a great Sunday.
Well, yeah, you too, man. Take it easy.